Welcome back to This Emergency Life, Episode 7, Casting a Wide Net, Finding Sepsis Early. I'm Kevin LaMonica, your host. Today, we dive into sepsis, not as a single disease, but as a complex syndrome. We'll walk through a real-world case, explore U.S. epidemiology and mortality, and focus on how frontline clinicians, especially nurses, identify sepsis using screening tools. By the end of today's case, you'll understand why casting a wide net can save lives. Imagine this. It's 3 a.m. in the emergency department. You are triaging when a 68-year-old woman, Mrs. Sanchez, arrives by ambulance from a nursing home. Her primary nurse reports she has been confused for 2 days. Vital signs: temperature 38.5 degrees Celsius, heart rate 110 BPM, respiratory rate 24 breaths per minute, blood pressure 90/60 mmHg, and a pulse oximetry reading of 92% on room air. The paramedics note she has foul-smelling urine in a Foley bag and appears lethargic. Right away, your mind goes to infection, possibly a urinary tract infection. But are you concerned about sepsis? Mrs. Sanchez's respirations and tachycardia meet some screening criteria, but is that enough? How do we decide whether she is septic and needs immediate intervention? That, my friends, is where screening tools like SIRs and Q-SOFA come into play. In the United States, sepsis is a silent killer. Approximately 1.7 million Americans develop sepsis each year, and nearly 270,000 die from it annually. Sepsis remains a leading cause of in-hospital mortality, consuming up to 20%, 30% of total ICU resources. Even survivors often face long-term physical, cognitive, and emotional impairments. For nurses in the ED, understanding the burden of sepsis is more than academic. It's seeing these numbers translate into faces. Patients like Mrs. Sanchez. Recognizing sepsis early can reduce mortality by up to 40%, yet delays in identification or treatment spike the risk of death by 7%, 10% for every hour that passes without antibiotics or resuscitation. That's why our focus today is on early recognition. Sepsis is not a single disease entity like pneumonia or appendicitis. It's a syndrome, a life-threatening organ dysfunction caused by a dysregulated host response to infection. That means two patients with the same infection might present, look different under the microscope, yet both meet sepsis criteria because their bodies respond in unpredictable ways. Imagine the host response as a thermostat. In sepsis, the thermostat goes haywire, either overreacting or underreacting. Early on, a patient's immune system might release inflammatory mediators, causing widespread vasodilation, increased capillary permeability, and tissue hypoperfusion. If uncorrected, organs begin to fail. Sepsis awareness demands we think about the patient as a whole. It's not just one pathogen or one organ malfunction. It's the syndrome, the cascade of events that can kill you. At the bedside, your first tools are vital signs and general appearance. Does the patient seem confused or lethargic? Are their skin and extremities mottled? What does capillary refill tell you? Each of these clues raises your suspicion. In Mrs. Sanchez's case, confusion and hypotension ring alarm bells. Remember, elder patients or those on beta blockers, even immunosuppressed individuals, may not mount a fever. Always do a head-to-toe assessment, fully exposed to look for cellulitis, abscesses, or signs of pneumonia. Check mucous membranes for dryness, examine the Foley bag for cloudy or foul urine, and auscultate lungs. Every piece of information feeds into your screening decision. Historically, we relied on SIRs, the Systemic Inflammatory Response Syndrome, to screen for sepsis. SIRS is positive when 2 or more of the following are met. 1. Temperature 38 degree or 36 degrees C. 2. Heart rate 90 BPM. 3. Respiratory rate 20 breaths, min or PaCO2 32 milliliter H gray. 4. White blood cell count 12,000 maybe 3, 4,000 may 3, or 10% bands. In Mrs. Sanchez's case, she meets 3. Temperature of 38.5 degrees, heart rate of 1 in 10, and respiratory rate of 24. But SIRs can be triggered by many non-infectious processes: post-operative inflammation, trauma, or even a simple viral infection. That's the criticism: high sensitivity but low specificity. Enter Q-SOFA, the Quick Sequential Organ Failure Assessment, introduced by Sepsis 3. It flags patients at risk of poor outcomes if they meet 2 or more of 1. Altered mentation, Glasgow Coma Scale 15. 2. Systolic blood pressure, 100 mush, 283. Respiratory rate, 22 breaths, min, Q-SOFA is more specific. If Mrs. Sanchez's mental status is altered and her blood pressure is 90/60, she scores 2 points. She's high risk for mortality. But here's where understanding sensitivity and specificity is critical. Sensitivity measures how well a test picks up true positives, patients who truly have sepsis. Specificity measures how well the test excludes true negatives, patients who do not have sepsis. SIRS is like a large industrial fishing net. You'll scoop up almost every fish in the sea, big and small, but some of that catch will be non-fish, false positives. Q-SOFA is like a child's handheld net. You'll catch only the big fish and some obvious ones, missing the smaller early sepsis cases, false negatives. For nurses, prioritizing sensitivity means you'd rather cast a wide net, SIRS, knowing you may pull in extra patients who aren't septic rather than risk missing someone early when they can still be saved. Used in isolation, Q-SOFA may miss a patient like Mrs. Sanchez until they're in full-blown shock. Ultimately, no single tool rules supreme. Many health systems combine SIRs for initial screening and Q-SOFA or full SOFA for prognostication. But every nurse should understand that early sensitive screens save lives. Once sepsis is suspected, labs and cultures become critical. Draw 2 sets of blood cultures before antibiotics, but don't delay therapy beyond that crucial first hour. Order a CBC with differential, metabolic panel, lactate, and consider arterial blood gas if acidemia is a concern. In Mrs. Sanchez, an elevated lactate, 2 millatramol L, would confirm tissue hypoperfusion. Meanwhile, get a chest X-ray, a point-of-care ultrasound if available, and retrieve urine for urinalysis and culture. Emergent diagnostics guide resuscitation. If lactate is trending up despite fluids, suspect source control isn't achieved. Maybe Mrs. Sanchez has an undrained perinephric abscess. Early identification of that leads to earlier urology consult. Every delay here jumps mortality rates. You've recognized sepsis. Now comes the initial management bundle. Remember the hour 0 bundle. First, give broad-spectrum antibiotics as early as possible, ideally within the first hour of recognition. For a suspected UTI-driven sepsis in a patient without resistant risk factors, that might be piperacillin tazobactam plus vancomycin. Simultaneously, start fluid resuscitation, a balanced crystalloid bolus of 30 millifric claws. Mrs. Sanchez weighs about 70 kilos, so that's roughly 2.1 L in the first 3 hours. Titrate based on her volume status. Insert 2 large bore IVs or consider an IO line if you can't establish peripheral access quickly. If she remains hypotensive after fluids, pressors, starting with norepinephrine, become your next step. While you're stabilizing hemodynamics, continue the search for source control, maybe a CT scan of the abdomen and pelvis if her creatinine permits. Adjust antibiotics once cultures return. Remember, early aggressive sepsis care is associated with lower mortality. Our case of Mrs. Sanchez would have easily been picked up on using Q-SOFA alone, but by using SIRS as our initial, we would recognize earlier presentations of sepsis and be able to intervene earlier. This approach may yield some false alarms, patients who meet SIRs for non-infectious reasons, but the alternative is missing early sepsis until it's almost too late. In the ED, every second counts. Teaching nurses to value sensitivity means valuing human life. Think of SIRS as your wide industrial net, messy, full of debris, but more likely to pull in every fish. Q-SOFA? A small net for the big fish only, missing the ones that are just starting to thrash. If we want to prevent avoidable deaths, we need to fish with industrial nets. 1. Sepsis is a syndrome, not a disease. It represents a dysregulated host response to infection, organ dysfunction from inflammation. 2. U.S. impact. 1.7 million cases and 270,000 deaths annually. Early recognition can reduce mortality by nearly 40%. 3. Screening tools. Differ. SIRS, high sensitivity, low specificity, scoops up many patients early but some false positives. Q-SOFA, higher specificity, lower sensitivity, identifies those already very sick but misses early cases. 4. Sensitivity versus specificity. Nurses should prioritize sensitivity and screening to avoid missing early sepsis. 5. Early management: draw blood cultures, start broad-spectrum antibiotics within the first hour, and initiate 30 mL kd fluid resuscitation. Pressors if hypotension persists. 6. Analogy: SIRs is the industrial net, wider, messier, but catches more. Q-SOFA is the child's net, neat, selective, and runs the risk of missing early sepsis. Cast the wide net, save the lives. Thanks for joining us on This Emergency Life. If you found this episode helpful, follow, subscribe, and share it with your colleagues in the ED. When you come back for your next shift, we'll tackle another high-stakes topic. Until then, stay vigilant, cast wide nets, and keep on saving lives.